our keynote speaker. I'm very, very excited to have him speak before us. His name is Dr. Adam Gaffney, MD, MPH. He's an assistant professor of medicine at Harvard Medical School, pulmonary critical care physician, Cambridge Health Alliance. He's a health policy researcher and a writer and commenter on issues of medicine and policy. His research focuses on national healthcare reform, healthcare equity, history of healthcare, and specifically disparities in lung health. He's authored or co-authored more than 60 journal articles, with his first author publication with publications in journals such as The Lancet, BMJ, JAMA, Health Affairs, American Journal of Public Health, elsewhere. He's also the author of the book To Heal Humankind, The Right to Health in History, which provides a inspiring and insightful analysis of the historical development of the concept of health as a human right. He's been published in numerous media outlets, including the New York Times, the Washington Post, the New Republic, et cetera. That's an et cetera that covers a wide swath of additional outlets. He's appeared as a guest speaker on a number of radio and television programs, WNYC, WBUR, MSNBC, Fox Business News, again, et cetera. He is currently a fellow at the Lown Institute, which is a nonpartisan think tank advocating for bold ideas, which is what we need, for a just and caring healthcare system. And in the past, he served as president of Physicians for a National Health Program, which is a nonprofit organization that advocates for single-payer Medicare for all healthcare reform. Dr. Gaffney received his MD from NYU, so he's in his home. He's back home in New York. He got his MPH at the Harvard T.H. Chan School of Public Health. He completed his residency at the Columbia University Medical Center, where he served as chief resident, and his fellowship in pulmonary and critical care medicine at Mass General Hospital, Brigham and Women's Hospital, and the Beth Israel Deaconess Medical Center. I think that's enough, but though we could talk more. Without further ado, here is Dr. Gaffney speaking to us on U.S. healthcare in a new political era. Thank you very much.
Well, good morning, everyone, or good afternoon. Thank you for that very generous introduction. And I just really want to thank everyone who worked to get me here and for the invitation to be here. And I'm going to be talking very broadly, and I'll warn you in advance, this is going to be a little bit of a whirlwind tour through what's happening in healthcare today, in healthcare financing, in healthcare ownership, in healthcare access, and in with the new political administration, with the new Trump administration. So hang with me, and we're going to get started with a 50,000-foot view. So let's just talk for a second about where we stand as a country from the perspective of health. So life expectancy over the last 60 years, seen here in the U.S., big gains in the 1970s, things slowed down a bit, but continued to improve in the next 3 decades. Obviously, a horrible plummet in life expectancy with the COVID pandemic. But what you'll see on this figure is that the decade before COVID wasn't very good either. Life expectancy plateaued, which is a historical aberration, and in some years even fell. And we know this is due to more than one thing. The opioid epidemic has, of course, gotten a lot of the blame. But as I'll discuss a little bit, it's more complicated than that. And so-called medical diseases, medical diagnoses, heart disease, diabetes, have also contributed. And I believe a portion of this can be explained by problems in our healthcare system itself, even though so much more than healthcare is responsible for our health. Now, this figure, of course, doesn't show differences among populations in the amount of time we have on this earth on average. Just one disparity is highlighted here in life expectancy between black and white individuals. And yes, there was a narrowing, particularly during the civil rights era up through the late 1970s, but a huge chasm remains. Gaps by socioeconomic status, of course, are also quite wide. And I'm going to say 2 things about this figure. This is showing age-adjusted mortality among those with and without a bachelor's degree. And you can see non-college educated individuals have a much higher mortality. That's known and been well described, particularly by Case and Deaton. Case Deaton. But what I want to point out here, this is from some ongoing work, this is not all-cause mortality. These are deaths, so-called healthcare amenable mortality. So these are deaths that are thought to be potentially preventable by high-quality medical care. Not always, but at least potentially preventable. And what you can see is that Americans with lower education, even before the COVID pandemic, have a slight increase in their age-adjusted mortality from potentially preventable medical problems. This really speaks to a crisis. Things are not well in health in the United States. And although we're coming out of the COVID pandemic, there are worrisome trends that predated those terrible years. Now, I said that a part of the problem might be in healthcare, and I believe that to be true. This is a figure showing that among individuals with diabetes, there has been a worsening in disease control. So you can see a fall in the share of individuals with diabetes who have an A1C of less than 7%, a fall in the share who have controlled hypertension. Similarly, among US adults with hypertension, we see a decline in hypertension control from 2013-14 and subsequent years. And again, this isn't about disease prevalence. This is about what we do on the healthcare side, treatment. Moreover, these sorts of adverse trends are not affecting everyone similarly. This figure shows hypertension control by income. So FPL is federal poverty level. The point here is the light blue line. You can see that higher income Americans, their hypertension control has more or less stayed stable, but it's worsened among lower income Americans, right? So again, I mean, there's not much, this is one of the critical things that we do in medicine and primary care, prevents strokes, prevents heart attacks, prevents death, and there's evidence that we're not doing as good of a job. We also see something like the surging rates of congenital syphilis, completely medically preventable, a tenfold rise in cases between 2012 and 2022. I'm not going to dwell on these issues much longer, but the point here is that I think we can do a better job, and I'm going to talk a little more about what reforms we need to do so. But again, the take-home point from my perspective is that even with the COVID-19 pandemic receding, U.S. health is faltering. Deficiencies in healthcare may be one part of the problem, but needless to say, issues in our environment, inequality itself, and so many other social and political forces are also important drivers of health that I will not be addressing. All right, so let's sort of move forward. I've laid the scene in terms of health. Where do we stand in terms of coverage and access to care among Americans? Well, we can start with health coverage, uninsurance rates. This shows the uninsurance rate from 1963 all the way up through last year, or 2 years ago, 2023. And what you can see is that in the 1960s, we had a dramatic drop in the uninsurance rate. That's because Medicare and Medicaid were passed during the civil rights era. You can see that during the 1980s, things got worse during the Reagan administration due to cuts in Medicaid, as well as a decline in employers offering health insurance. And those cuts in Medicaid we should put in the back of our head for a second, because that's now looming now in 2025. And we can see things got better again with the Affordable Care Act. And actually, they got better even with the pandemic. Why is that? Well, when the pandemic got underway, Congress passed a law that helped patients stay in Medicaid. Patients with Medicaid often lose access to coverage because they don't fill the forms out in time and so forth, what's called churn. And that stopped for a while due to emergency pandemic legislation. That has now that is no longer in effect. And so there's been a major unwinding of Medicaid. Millions of people have lost Medicaid over the last year, and we have seen a rise in uninsurance now in the official statistics for 2024. So as a consequence, from April 2023 to July 2024, Medicaid enrollment fell by about 13 million. And again, Medicaid is, I'm sure everyone's familiar, but it is the sort of joint federal state public insurer that provides insurance for lower income Americans. So the Congressional Budget Office is projecting, absent any sort of further change, which is optimistic, that the uninsurance rate will rise to 32 million by 2027. And this is going to have very adverse effects on Americans' health. Just to give a sense of what these numbers mean in terms of life and death, I've put up here the number needed to insure to prevent one death across 5 different high-quality, quasi-experimental studies. The exact numbers don't matter, but what you'll see here is that somewhere between 278, 830 people you insure to save one life, which means when you have 30 million people uninsured, tens of thousands of unnecessary deaths are happening annually. And so this is the kind of framing and this is the kind of way we need to think of these issues. It's not just about financing, it's about life and death of our patients. Lack of coverage is not, of course, the only form of barrier to care. And for many Americans, the bigger issue is out-of-pocket payments. So what are out-of-pocket payments? There are obviously things like co-payments, a fixed amount you pay every time you go to the doctor, deductibles, an amount you pay before insurance kicks in, co-insurance, a percentage of the healthcare cost that you pay out of pocket, or you pay the whole thing if you go out of network and don't have coverage, or if you don't have insurance, you may be liable for a full payment. But even if you have employer-sponsored private insurance, which has relatively low cost sharing compared to, say, a marketplace plan, your deductible for a family on average might be $5,000 if you have a high deductible plan, or maybe as low as $2,000, $3,000. But you can see that is going to be a very high percentage of the annual income of many families and can make healthcare completely unaffordable even for the insured. And what we know from study after study after study is that when you make these high payments, when you impose these cost barriers, people go without needed care. And this is just a very, upsetting study. It was a quasi-experimental study that looked at what happens when women with breast cancer are sort of pushed into a high-deductible healthcare plan. And then they compared that to a control group that had full coverage and didn't get those new costs. And this study found that this led to major delays in breast cancer care, up to 0.6 months for diagnostic imaging, 2-month delay in breast biopsy, and 7-month delay in breast cancer diagnosis, and an 8-month delay in initiation of chemotherapy. This was published several years ago. So this is one study. I could show this sort of phenomenon for many other conditions. I'll have one more recent study that had a similar design. What happens when you push people into a high deductible healthcare plan? In this case, among patients with diabetes. And it found that compared to a control group, it led to a 11% increase in the odds of a myocardial infarction, a 15% increase in the odds of a stroke, a 35% increase in the odds of a CHF hospitalization, and so forth. So people go without needed care. And in fact, even when these payments are quite low, there can be adverse consequences. This was a study published by some very prominent health economists that made waves when it came out, again, uses a sort of quasi-experimental design, and found that even relatively low co-payments among Medicare beneficiaries caused them to go without medications and cause an increase in mortality. Which is not surprising. If you stop taking your blood pressure medications, you may very well have uncontrolled blood pressure, and that can lead to a serious adverse event. And certainly, working in my clinical work is almost entirely in the intensive care unit nowadays, and I see this. And if you don't ask, you might not actually realize it. But you speak with patients there for acute pulmonary edema, complications of chronic renal disease, diabetic ketoacidosis, and once you start getting beneath the surface, you will find people who, for whatever reason, lost coverage, fell out of care, didn't have coverage for prolonged periods, fell out of care. And this also affects use of prescription drugs. This was a study that we did, I guess, a couple of years ago now, just trying to put a number on how many Americans go without insulin because of cost barriers. And we found, using national survey data, that 1.3 million adults with diabetes who use insulin said they rationed their insulin to save money, whether by skipping doses or delaying buying. And that's about 17% of the total insulin users. So the take-home point here is that, that first figure I showed with the uninsurance rate, uninsurance rates are at very low levels now, but we remain very far from true universal health care, which I might define as single tier, meaning equitable, and seamless care over the lifespan for all of us. And that's not the only problem. As I said, with the Medicaid unwinding, uninsurance is starting to rise, and it could surge if the major Medicaid cuts that are now under discussion in Washington are passed into law. I want to talk a little bit more about, I want to talk about a different issue, about the privatization of our public insurers, okay? So this is the second part of my privatization will be about the delivery of health care. And what is underway in that sphere. So Medicare passed, as we discussed, in the 1960s, during the Civil Rights era, signed into law by Lyndon Johnson, a public program for older adults, 65 and older, subsequently was brought in to cover some additional groups. The decision was made at some point to allow private insurers to begin to offer Medicare plans. What has happened over the last, what I have here, about 20 years, is that these are called Medicare Advantage plans, sold by private insurers, but publicly financed. Medicare Advantage plans are taking over the market. Their market share reached 54% in 2024, so more than half, and that's projected to rise to 63.5% over the coming 10 years. Now, why do people elect to have Medicare Advantage over traditional Medicare? It's a complicated question. They are aggressively advertised. I don't watch too much network TV, but I'm told that or TV in general, but I'm told that on certain channels at certain times you're deluged with ads for Medicare Advantage plans. This was an article in the Times recently. Dr. Oz, now CMS nominee, he promoted Medicare Advantage plans on his talk show and encouraged people to sign up and made money from that. So there's a major advertising component. They also do have lower out-of-pocket costs and offer some additional benefits that's attractive for some individuals. But the problem here is that they are also very wasteful, okay? Why is that? Well, when you bring the profit motive in and you give this public insurer to the private insurance industry, they use a number of techniques to increase payments. So these, probably the two big ones, are upcoding. So this is when physicians or nurses are encouraged to more aggressively code diagnoses and improve, and that is what determines the payment, the capitated payments, as well as avoiding sicker patients and seeking out healthier ones. How is that done legally? There's a wide variety of methods, but it can include targeted advertisements to healthier seniors and other tactics. But the long and short of it is that MedPAC, which is the nonpartisan Medicare Advisory Board, has estimated that in 2024, Medicare Advantage plans were overpaid about $80 billion relative to what would have been spent had those individuals been enrolled in the traditional Medicare program. Okay, and over the 2007 to 2024 period, that totals about $591 billion. So this is a serious problem because it's taking money away from the Medicare program itself and going and diverting it into the profits of insurance companies and their administrative overhead. I mentioned a little bit about the upcoding problem, and so this is one way of looking at that. Okay, so I'm just going to explain what's going on here. It's a complicated figure. So Medicare Advantage plans will send nurses into patients' home to do a single home care visit. And so you can see that on the left side, traditional Medicare versus TM versus Medicare Advantage. Medicare Advantage plans have 31 times more likely, or the beneficiaries are 31 more times likely to have exactly one home care visit. And that's because that visit is probably geared towards upcoding. Whereas among those in receiving longitudinal home care, 2 or more visits, you can see actually a higher proportion of traditional Medicare patients. So this is an example of a business practice that's increasing payments but not actually helping care. And these in-home health risk assessments and chart reviews increase payments by probably $3 to $15 billion a year. And despite this, Medicare Advantage beneficiaries are receiving less care. So it's more expensive, but it's less care. This is just looking at the average resource use. Physicians' visits, home care, all the things that we provide to beneficiaries across a range of conditions. And across that range of conditions, you can see that Medicare Advantage beneficiaries receive much less medical care. And so this is what we sort of describe as the Medicare Advantage paradox. The privatization of our public insurance system, Medicare, is leading to less care at a higher cost. And I'll say, just as a final note on this issue, it's not just about inefficiency. Many patients of less means are attracted to Medicare Advantage programs because they're able to offer things such as zero premium drug plans, right? And so what we're seeing is a separation of the Medicare pool into different programs where non-white populations and lower income individuals are more likely to go into Medicare Advantage plans, and higher income and white populations are more likely to go to fee-for-service. So we're fragmenting out this pool of people who could now not necessarily all go to the same doctors, and that kind of undermines this sort of idea of Medicare itself, which is a single tier program for everyone 65 and older. So takeaway from my perspective is that Medicare Advantage isn't only siphoning money out of the system. The business model is based on care denial, right? Patients get less care because there's more prior authorizations, there's narrow networks, they can't necessarily go to every doctor, every hospital, and that's undermining the idea of an equitable Medicare system itself. I want to talk a little bit about what's happening in terms of ownership of care and the providers of care. So this is from some work we published a few years ago, just looking at the big picture question of what sorts of entities own our healthcare facilities, hospitals, hospices, and we'll go through them. But from a perspective of hospitals, nonprofits still dominate hospital ownership. Public ownership has been declining since the 1970s, as you can see here, and there has been a rise in for-profit hospital ownership. In other areas of our healthcare ecosystem, for-profit corporations are really taking over. So hospices in the top right-hand corner, traditionally, thought of as to be religious or nonprofit service provided to people at end of life, has been completely gobbled up by for-profit corporations. Dialysis facilities for a long time have been dominated by for-profit corporations, 2 big companies in particular, home health agencies, nursing facilities. And there's problems with this. I'm not going to be able to go through it in great depth, but one just very simple example is that, not surprisingly, for-profit hospitals are more likely to offer what are viewed as profitable services, certain types of elective surgical procedures, for instance, and are less likely to offer services that are sort of thought of as unprofitable, whether that be substance abuse treatment, mental health care, or primary care. Now, separate from whether these entities are for-profit or nonprofit or public, the other development that it's important to be aware of is the unprecedented horizontal and vertical integration within the healthcare ecosystem. So just to give the example of United Health, which we heard about just a minute ago, we think of United Health as an insurer, and it is. It's the largest insurer in the nation, 27 million privately insured, 20 million sort of Medicare, Medicaid managed care. Actually, those publicly financed managed care plans are actually more revenue nowadays for these insurers than the traditional private insurance. But they also are, arguably the largest employer of physicians now in the United States. They own or are affiliated with 90,000 doctors. They also, their Optum Insight brand takes care of, it processes bills. They were at the center of that big fiasco with the data breach of Change Healthcare that you may be familiar with. So they manage medical bills totaling $1.5 trillion, and their mail order pharmacy division handles 1.4 billion prescriptions. So this is a very novel development historically to have one entity having such broad-reaching control over so many different parts of our healthcare system. Another development that's been very in the news that I want to mention is the role of private equity in healthcare. Private equity firms, have a very sort of aggressive approach towards profit making. They make very short-term investments, 4 to 7 years, that they typically flip their assets, the firms they purchase, and they have these leveraged buyouts that pool funds from investors that allow them to sort of take over these companies. And in the healthcare space, it's really been a disaster. To give a few specific examples of private equity takeovers in the nursing home space, for instance. Carlyle Group, big private equity firm, took over Manor Care, a nursing home chain in 2007. And because of the business model, the name of the game is short-term profit and not really worrying about what happens in the longer term because they're not going to hold on to it for a long time. So after they did this, they had Manor Care sell off almost all of its real estate. That made $1.3 billion for the investors, but now the nursing home had to rent back its facilities from the new landowners, burdening it with unsustainable costs that required layoffs, cost cutting, and then with it, health violations, and then ultimately Manor Care filed for bankruptcy in 2018. I'll say something about what happened in Massachusetts that I think was national news that you may or may not have heard of, but we had what was described as a hospital nightmare in Massachusetts. So this is the sort of saga of Steward Healthcare. So long story short, nonprofit healthcare chain owned by the Catholic Church in Boston, sold off its hospitals to Cerberus, a private equity firm. Cerberus is it's named after the dog in ancient Greek mythology that guards hell. I'm not sure why they named it that. It's not really a great name for someone involved in healthcare. But anyway, they took a similar road. They sold off a lot of its possessions. And in 2016, the big one was selling off the hospitals themselves, the real estate meaning. And now once you sell, and that generated $1.2 billion in payoff to their investors, but it saddled the hospitals with unaffordable rent. And it was a sad story after that. They sold it to new physician owners in 2020, not really wanting to be in that business anymore. Those new physician owners made $111 million in dividends. The CEO bought a $40 million yacht. And subsequently, things went downhill. Spiraling finances, deteriorating care, unpaid bills, shortages, hospital closures, understaffing, filed for bankruptcy. As part of this, 2 of the hospitals closed, one of them in a predominantly African-American community. Taxpayers got hit with $489 million in bailout costs. While this is all happening, the CEO took his $40 million yacht to the Galapagos. And it's not just there. This is a study from our research group led by Elizabeth Schroeder, which looked at this phenomenon of PE acquisition and what hospitals do with the ownership of their capital when that happens. And you can see that after private equity takeover, hospitals lost 24% of their capital. when I say capital, I mean physical capital, building, equipment, land. So it's a strip mining approach. And there are medical consequences that have been described in the literature. After private equity acquisition, hospitals see a rise in complication rates, hospital-acquired conditions go up 25%. And this is taking place in other spheres, not just in hospitals. PE is acquiring cardiology practices across the country, behavioral health facilities across the country, hospices are being taken over. And so this is not a positive development, is at least my opinion. But it raises a broader question, which is who should own our vital healthcare infrastructure? Should it be profit maximizing or asset stripping firms, or should it be communities and the public? I'm going to talk a little bit about the supply of care in the United States. This is something that people talk about a lot. We don't have enough doctors. You hear that. But I want to make the case that it's a little more complex. Yes, the U.S. does have fewer doctors than other countries, but that's actually, you can see we have much fewer generalists, but we actually have about medium to high levels of specialists. So it's a distribution of types of physicians, not necessarily an absolute shortage. And as a result of that, and this gets back to the problem of declining health itself, this was a study that we did a few years back. We as Americans spend less time annually in front of a primary care doctor year after year. That's been going down since 2005. So we're not actually getting as much primary care. And I think that could be driving some of the problems we see in terms of health outcomes. And it's not just, the distribution of specialties. It's also about where physicians are. There's just one study. You could do many others like this, just showing that primary care, and really any kind of care, is less present in communities of color and communities with higher uninsurance rates. Similarly, communities of color are more likely to lose ambulatory care facilities or pharmacies. And this sort of maldistribution plays out in the hospital side as well, in terms of where we put money. During the COVID pandemic, communities in the hardest hit areas didn't always have as much resources as communities that were hit less hard. This study found that low-income communities, 49%, don't have a single ICU bed. Compared to high-income communities, almost none lack ICU beds. Similarly, in terms of hospital closures, Black communities are at increased risk of losing hospitals. So hospitals in the top quartile of Black population share have about a four-fold higher odds of having a hospital closure, of losing their hospital. And when you look at hospital capital assets, so capital assets meaning dollar value of land, of equipment, of all that, Black serving hospitals have about $5,000 worth of capital per patient bed day compared to $8,000 at hospitals that serve other communities. So there's a maldistribution in our facilities and in our infrastructure that is a problem. So even though we have such high healthcare spending, we generously fund healthcare in our society, it isn't necessarily where it needs to be. This is what the epidemiologist and British general practitioner Julian Tudor Hart termed the inverse care law. In a famous Lancet article in 1971 that's been cited, 10,000 times, he wrote that the availability of good medical care tends to vary inversely with the need of the population served. And people cite that often. What he also said, though, was that that was partially a reflection of the operation of a market economy. In other words, that if we allocate, if we put healthcare infrastructure where people can afford it, then it's not going to necessarily, it's not going to go to where it's needed. So we should think more about how we should allocate healthcare capital on the basis of communities' health needs, not on their wealth. I'm going to ask one question. How much time do I have? I just want to not go over. 5, 10 minutes, okay. Very good. So I'm going to talk a little bit about the economics of healthcare reform. I've been sort of describing what I think are some of the inadequacies and some of the deficiencies in the way we fund healthcare in the United States. We've talked about uninsurance so far. We've talked about underinsurance. We've talked about how healthcare infrastructure is distributed and planned. But let's just say we want to move forward. Let's say we wanted to do something new. How would we finance that? How would we fund it? So I'm going to make two main points in that regard. This was from a study from a few years ago that we did, looking at the share of total healthcare spending that is taxpayer financed. And there's two lines. The orange is the share, what I said, unadjusted. And what I mean by that is that's just the public payers. So that's the share of total healthcare spending that's accounted for by Medicaid, by Medicare, Department of Defense, VA, the big public payers. But that's not the whole, and if you look at just that, that's about 50% of healthcare spending. But that's actually not the end of the story, because private health insurance is heavily subsidized by taxpayers as well. There's a tax exemption for private health insurance, but there's also funding towards the ACA marketplace plans, there's subsidies, and there's also the health benefits of local, state, and federal employees, that they may be private health insurance plans, but they're already being financed by the taxpayers. So if you add all that up, if you add up all of those programs and all of that federal subsidization, about 70% of US healthcare spending is already publicly financed, right? So when we talk about healthcare reform, we have to keep in mind that in many ways, American healthcare is already predominantly publicly financed. In a way, we're paying for a national health insurance system, universal health care, but just not getting it. So that's the first point I want to make about healthcare reform. The second point I want to make is that there are inefficiencies that we could harness or eliminate in order to fund an expansion of care without increasing our total healthcare spending. In other words, to achieve healthcare reform in a sustainable and economically sustainable manner. So what I have here is the simple issue of insurance overhead by payer. So insurance overhead is a proportion of revenues that an insurer takes in that does not go to healthcare, meaning it doesn't go to the hospitals, the doctors, or the drug companies. This is sort of internal administrative overhead. What we see is that private insurers have far higher overhead than public insurers. So Canada, about 2% overhead. Traditional Medicare varies between 2 to 3%. Private insurance and Medicare Advantage plans, 3-4 fold higher or more. And why is that? Well, private insurance has a lot of private insurers have a lot of things they need to do that public insurers do not. Product design, high executive salaries, profits to shareholders, large apparatuses to deny care for prior authorization. All the things that they do adds up to a huge amount of money. And while this 5, 6, 10 percentage points may not sound huge, when you think about the fact that healthcare is a $4 trillion industry, well, you're talking about a huge amount of money. If you look at this from a sort of big picture perspective, U.S. healthcare spending on administration in the United States is about double that of Canada as a share of total healthcare spending. So we spend about 1/3 of healthcare dollars on administration in the U.S., and that's about double the proportion of Canada, where it's about 17%. And that gives us room, if we were to move to a new style of healthcare system financing, to achieve a lot of savings to pay for the upgraded care that all of us could receive. Hospitals are also burdened with a lot of costs because of the fragmented nature of our healthcare financing system. They have to work with innumerable different insurers, each of which have their own rules and regulations. They have to contend with rejections of bills, denials, and so forth. So we spend about, they have to hire large numbers of billers and coders to do all this work. So we spend about twice the proportion of Canada on hospital administration as a share of total hospital spending. And physicians' offices are similar. Per physician spending on interactions with insurers, this is dated figures now, but it's about $80,000. And that's about fourfold higher than what gets spent in Canada and Ontario on physicians' administrative costs. So the takeaway here would be that a single-payer style national health insurance reform would allow for the repurposing of hundreds of billions of dollars of that spending on insurance overhead to medical care. All right, I want to finish up and wrap things up with just a little bit of a look about where we stand now in terms of policies and things that may be coming down the pike. So some of you may be aware, and how it relates to some of the other issues I've discussed. So many of you probably are aware that the House recently passed a budget resolution that it's going to be working towards in order to pass a reconciliation bill sometime this year. And this is calling for huge tax and spending cuts. So I've just sort of simplified it on a graph here. This is the figures that are called for in that proposal. So the idea on the top row, you'll see that there's a $4.5 trillion increase that would go to Ways and Means. And that just means about $4.5 trillion in tax cuts to extend, and that's really just extending the tax cuts that Trump passed in his first administration. So, and that's how much it would cost. So where are the savings going to come from? Well, the biggest thing they're calling for in terms of savings to offset those tax cuts is from Energy and Commerce Committee, and that's the committee that oversees Medicaid and Medicare. So $880 billion is the goal right now, and what that's going to translate to, if it happens, is almost certainly very large cuts to Medicaid. And that could take the form of different sorts of proposals. Right here, I've listed sort of just 6 of those possible cuts that the House Budget Committee circulated as potential options. And so, this ranges from things like per capita spending caps that sort of constrains the growth of Medicaid, eliminating the ACA Medicaid expansion, enhanced federal funding, and work requirements, which were put forth in Arkansas during the first administration. But the long story short here is that if this were to pass if reforms like this were to pass, we're talking about really deep cuts to Medicaid financing. And what that's going to translate to is most likely up to millions of more people losing health coverage. We're working on trying to put some estimates on that. But really, all the various problems I've been describing in this talk so far in terms of uninsurance, lack of access to care, and declining health would be exacerbated by this. It would also be punishing for safety net providers. Will that happen? I don't know. Interestingly, and maybe surprisingly, universal coverage, Medicaid, and Medicare are all actually very popular programs. This is some polling that was published a year ago, and I just found these to be interesting figures. When you poll Americans, 65% say it is the responsibility of the federal government to make sure all Americans have health care coverage. 81% say they have a favorable view of Medicare. 74% say they have a favorable view of Medicaid. So really, to achieve those Medicaid cuts would be going against a very popular program and be going against popular sentiment. And I think that gives grounds for optimism that perhaps this agenda can be resisted. I'm going to end there. Thank you for putting up with a very broad talk, and it was really good to be here.
Thank you so much. It's greatly appreciated, Dr. Gaffney. It was a broad talk, but it covered a lot. I took copious notes that I will have to pour through later at my leisure. I really appreciate it. I wish we even had more time.